Ladies and gentlemen, could we please be seated? I know some of you by names, and I will not shy away to call you to be seated. Thanks. We'd like to get started with the last panel of the day. Thank you. I'd appreciate if we all have our seats so that we could get started on this last but very important session. Thank you. My name is Alan Maleche. I work for an NGO in Kenya called KELIN that focuses on health and human rights, but I also have the privilege to sit on the board of the Global Fund to Fight Tuberculosis and Malaria, representing developing countries, NGOs. I'm honored to be part of this historical moment that will lead us to having a strong declaration signed on by all heads of state that commits to fulfilling the rights of those affected by TB. I want to believe by being put on the fourth panel, we have saved the best for last, and that we have not put human rights at the end of the conversation. This evening, I'm joined by very important colleagues who I will introduce shortly, starting with our storyteller, who is Blessy Kumar. She's the CEO of the Global Coalition of TB Activists, Activist Coalition of TB Asia, Pacific, and Indian Coalition of People Affected by TB, Touched by TB. You'll hear more from her later. I'm also pleased to introduce my learned colleague, Timur Abdullayev, who is a human rights lawyer from Uzbekistan. He is a person living with HIV and also a TB survivor, and the only lawyer beyond Justice Edwin Cameron who is open about his HIV status. He is a board member of TB People, the global network of people affected by TB. We're also going to hear from Connie Sidul, who is the founding executive director of the Akausvik Inuit Family Health Team, based in Ottawa, Ontario, Canada, who provide primary care to the largest group of Inuit people outside the Arctic North. We will also hear from Maxine Lunga from the Democratic Republic of Congo, who represents Club des Amis d'Amain and chair of the National TB Civil Society. And then finally, we'll hear from Delena Gracia, who is the director of International Projects and Emerging Issues with Migrants Clinicians Network. That's the panel that's set to speak to you. We will speak about their topics, but before we go to that, I have to follow the rules and protocols. I will not remind you that you can now start pressing your buttons in order to get onto the list to speak, but we want to take and acknowledge the fact that we understand that a lot of people are asking to make interventions and are not being called upon. We are doing our best, and especially particularly in this panel, to include as many people as possible, and we appreciate your patience and understanding. We wish we had time for everyone. So what I've talked with my panelists is that they will keep it short to ensure that they have more time for you to be able to make your interventions. And in the spirit of not leaving anyone behind, we trust that you'll also make your interventions short so that as many people can speak, because I believe this is the last time to speak, or forever you may have to hold your peace. So let's keep that in mind, and I will quickly frame the conversation around this panel. This panel stems from the key ask number 2, which seeks to transform the response, the TB response, to be equitable, rights-based, and people-centered. We will speak about the roles of communities in an equitable, person-centered, rights-based response, but that is more of a code of saying we shall talk about human rights, why human rights matter, and why governments must put human rights at the center of the TB response. And we'll also speak about an important piece that crowns everything in this conversation. How do we hold our governments accountable to the targets, to the legal obligations they've already signed on, to the commitments they will make at this particular conversation, so that we don't have to sit here in another 5 years still speaking the same story about TB. So with that, I will pass it over to Blessy Kumar to share with us her story.
Good afternoon, everyone. Thank you, Alan. There are hundreds and thousands of TB stories, some with happily ever after ending. But even these stories are of tremendous stories of courage and resilience, because overcoming TB is truly a battle. Every TB story should be a story of success, of being diagnosed early, being put on the treatment early, with all the needed social, psychological support provided. However, this story is only found in books, guidelines, policies, and reports. The real TB story that all of us experienced is very different. It is of people struggling, running from pillar to post for diagnosis, seeking legal measures to get access to new diagnostics and new drugs, and knocking at different doors for care and support. Added to this is the whole social aspect and the rights of the individual with TB that are overlooked on a daily basis. Over all this looms the biggest struggle, which is the stigma associated with TB. An 18-year-old girl with drug-resistant TB needed one of the newer TB drugs and came to one of the best hospitals. Unfortunately, her place of residence was outside the hospital's jurisdiction, so she was not given the drug, even though it would mean saving her life, and the drug was available in the hospital. She had to go to court, and she won the case and got the drugs, but they were given at a hospital 1,000 kilometers away. She got the drugs that she so desperately needed to save her life, but it left her and her family bereft of all savings and more. Moving so far away to a big city, a bad city, a scary city, with only her father, staying there for the duration of the treatment, a long time. The worry, the stigma, the stress, definitely not easy, definitely not people-centered. TB today is so medicalized that the human aspect is completely missing. It is no more about people. A paradigm shift is needed to put people at the center. Policymakers, heads of missions, and governments who have signed on to end TB by 2025 and 2035 need to listen to and be willing to put the people affected at the center and then plan what his best approach would be and invest in resources needed. If TB was only a medical problem that needed biomedical solutions, we would have ended TB a long time ago, decades ago. But it isn't. We who have been through this, and the many hundreds and thousands that we work with, know this firsthand. So enough with keeping the affected community at the fringes. It is time for true partnerships, meaningful partnerships, with the missing link in the TB response, which is the community. We will light up lives and end TB only if we have the courage and the will to be on the side of the affected and value the community and be willing to invest. Thank you.
Thank you for a very powerful story, Blessy. We will quickly move to Timor.
Good afternoon. Every year, over 10 million people get sick with TB. Of them, 40% do not even receive care. They are missed by health systems after failing to be diagnosed, treated, or reported. Many of them are missed due to the fact that TB programs have been ignoring the human rights dimension of the epidemic. Stigma and discrimination makes people avoid diagnosis and treatment. As a community activist, I know hundreds of stories of how neglecting human rights has been undermining TB responses. I will give you just 3. So the first one, there is an expat person who develops TB symptoms, but he fears seeking diagnosis and treatment because, as a foreign national with TB, he can be subjected to deportation. He was so desperate that he was seriously considering committing a suicide. Evidence suggests that threat of deportation, in fact, increases the spread of TB. Expats who fear being sent home will not report symptoms. And still, there are many countries who deport people with TB. This is not a right-based approach. The second one, several people get arrested for not adhering to their treatment and put in jail. Not in the hospital, but in prison, with no infection control whatsoever. It took action by civil society groups. It took months of litigation to overrule the sentence, and it took years of litigation to compel the government to change the system. Most TB programs would agree that imprisonment is not a solution to non-adherence, but still most TB programs continue considering compulsory hospitalization as an effective tool to force people to follow the treatment. According to WHO guidelines and international human rights treaties, compulsory hospitalization can be used as a measure of last resort, when everything else was tried and failed. And still we continuously learn about the cases of compulsory hospitalization used in different parts of the world to force people with TB to comply with their treatment without addressing the root causes for their non-adherence, such as depression, severe side effects, and the need to support their families, to name just a few. This is not a right-based approach. A mother with TB is separated from her baby for the entire duration of her treatment, including the period when she was no longer infectious. As she is a single mother, her baby is placed in an orphanage, where she spent almost 2 years. This is a violation of the rights of the mother, and this is a violation of the rights of the child. This is not a right-based approach. The international community has already agreed on universal human rights that all people, including people with TB, are entitled to. So there is no need to invent new rights. However, the reality is that for many people with TB, diagnosis becomes the point when they cease to have their rights. If we allow this to continue, we will never be able to end TB. So the political declaration has to stress that only by ensuring, respecting, and protecting human rights of people with TB, the world will be able to end the epidemic. The political declaration has to demand that the global TB response must enshrine as its first tenet the human rights and dignity of all people infected and affected by TB. Thank you.
Well said, Timur. I couldn't have said it better to link all the kind of human rights violations different people have faced in the pretense of having to get a good treatment. We'll move over to hear from Connie, who will speak to us about an important group of people that she serves and how her experience has been in Ottawa. Thank you.
Thank you. Unusaku Connie Uyunga, a Kausivik Inuit Family Health Team Mingaktunga. Hello, I'm Connie Sadu at the Kausivik Inuit Family Health Team in Ottawa, Canada. Thank you for the opportunity to address the group today. I'll take you through a brief snapshot of the TB Inuit population health picture, risk factors, what can be done, and calls to action. Canada is considered a low TB burden country. Yet the TB amongst Inuit Nungangat is more than 300 times the rate of the mainstream population there. Inuit are also overrepresented in TB diagnosed cases in Ottawa, which is the largest concentration of Inuit outside of the north. 3 of the 4 Inuit regions, Nunavut, Nunavik, Nunatsiavut, have active TB rates comparable to WHO identified highest burden countries like Angola and Bangladesh. Rates in these Inuit regions ranges from 179.1 to 248.4 per 100,000. Risk factors. The TB burden for our community is compounded by multiple intense health disparities, comorbid chronic and acute conditions, mental health and addictions, housing and food insecurity, and mortality. Also, delays in care through lack of infrastructure, lack of trust in mainstream providers, and lack of cultural competency by providers in how to interact with patients and persons increases the risk of complications and mortality from TB. Inuit life expectancy is anywhere from 10 to 17 years less than the mainstream population, and that gap is growing. What can be done? Eliminate barriers to access of care. People-centered care, Inuit people-centered care effectively comes from within and by the community. For example, the Kausivik Inuit Family Health Team is the only model of care of its kind dedicated to Inuit population health. We have a 100% Inuit community member board. Mary Simon is our president. Access of Kausivik services has witnessed a 40% increase over the last 1.5 years. Prior to our startup, 97% of Inuit community members did not have a primary care provider. Why people patient-centered? Because recognizing the presentations of pain and lived realities, which are very different for our population members, requires a heightened vigilance and expertise. We, for instance, had a young Inuk male come in for rib pain. He thought he had broken a rib. It turned out to actually be bilateral TB on X-ray. It was only through chance and through the trust in providers that TB can be picked up when someone comes in and presents for another reason. Our people-centered primary care also allows work with specialists like Dr. Alvarez to overcome technical, jurisdictional, information flow, and other barriers. We were having trouble getting X-rays for those without a health card number, without OHIP, or any ID whatsoever. This can now be done without incurring any costs to the patient. We have also identified some limited Kausivik funds for the IGRA blood testing so that persons in need can have one without worrying about the cost again, which is about $150 per test per person. Calls to action, we have 3. Support the existing provider work, primary and tertiary, because the frontline care for Inuit is overburdened, and we're struggling to keep up with the intense demands facing us each day. Support resources for primary care models like the Kausivik Inuit Family Health Team. This will effectively increase health services uptake, and that's critical. Support political advocacy organizations and governments to mobilize what is needed. These are all readily achievable actions which will help us save Inuit and Indigenous community member lives. Thank you.
Thank you. Really appreciate that intervention, Connie, and thank you for sharing it with the rest of us. We now move to our next speaker, Maxime, and he will be speaking in French. So if you're not a French speaker, please, let's do the necessary. Maxime, over to you.
Merci, Alan.
Thank you, Alan. Good afternoon to you all. Ending the epidemic of TB by 2030, as indicated in the Sustainable Development Goals, in the End TB strategy, indicate a change of paradigm so as to respond to tuberculosis. These changes require people-centered approaches based on human rights and with a gender-sensitive approach. All partners must participate in this fight. The global level awareness of tuberculosis is not well spread throughout the population. Some attitudes and practices, as well as some behavior, are obstacles to the acceptance and observance of treatment. Treatment for tuberculosis is therefore a major channel to cut transmission chains. Current policies do not take into account the specific needs of key populations and do not facilitate care of those who have been taken ill, taking into account human rights. Tuberculosis is an issue for populations themselves. The situation is becoming more and more concerning with greater co-infection with HIV and an emergence of ultra-resistant tuberculosis. If specific decisions for effective action are not taken as soon as possible, we will not be able to eliminate tuberculosis by 2030. Due to the diversity, the community of partners to combat tuberculosis must carry out awareness-raising and appeal activities. This will lead to improved diagnostic procedures and better treatment for tuberculosis, also to active research for better treatment and the mobilization of local resources that must be used. In the DRC, TB activities are being carried out by several communities, but it is less than 30% of what is needed. Although their contributions are well known, however, the community is not well committed. There is a lack of coordination and a lack of funding for these community-based activities. Therefore, some populations have never been made aware of tuberculosis. And stigmatization, discrimination, and marginalization of those taken ill, as well as a lack of access to treatment and diagnoses, especially from rural populations, these remain major challenges that the national TB programs cannot overcome. Limited means do not cover all the activities in the National Strategic Plan for Tuberculosis. The limited number of partners that can provide financial and material support is also an issue. Communities have created a TB community platform at the national level, which allows for new organizations to work to combat TB. Parliamentarian and partnerships have been put into place, and the First Lady of the country has committed to combat TB, including celebration of World TB Day in 2018. Tuberculosis response requires education from all partners at all levels and in every stage of the fight against TB. The government must provide sufficient funds for community organizations to act on the ground. This is the only way to achieve the established goals in the appropriate timelines. The community must ensure a person-centered, balanced approach by participating actively in community surveillance of TB. Development of community watch groups for TB allows for early access to care, to diagnosis, to higher quality treatment, and to care for all those who are taken ill without any discrimination of sex, religion, age, tribe, social rank, etc. It must work with national tuberculosis programs to raise awareness and to collect data on TB and HIV. There must be a legal basis for equal access to care for all, and as well as increased focus on targeted care for those key populations. The community must work to ensure that there's diagnosis on the basis of the Stop TB Partnership. This is crucial. There must be new national policies put into place that recognize human rights, including those of the key populations, taking into account gender aspects, and to improve the contributions of civil society, communities, and the main populations that are affected by TB. There must be more effective integration of civil society, local organizations, and those affected by the fight against TB, and there must be the allocation of permanent and sufficient funds for community action. It is time to react and to act effectively. Thank you.
Thank you, Maxime. Very important and clear interventions on how states can involve the community and why it's important to be able to do so. Merci. Danila, up to you now.
Thank you so much. So for nearly 30 years, I've worked daily with the clinical network to address the health needs of those who've relinquished the anchor of family, community, and culture to seek a life of safety and a better future for themselves and those they love. For those many years, I've been told that migrants cannot be engaged in treatment for TB because of their mobility and their unwillingness to adhere to the lengthy regimen, or that they will only cause an explosion of multi-drug resistant TB, infecting the communities that receive them. For more than 20 years, I've been a member of a team that has assisted thousands of women, men, and children complete their treatment for TB disease, even as they scramble to find work, housing, education for their children, and frequently food. Much of this care is provided by clinicians that themselves are migrants, having left their homes to bring their language and cultural skills to this critical work, often at considerable risk of exposure and illness with TB because of the absence of attention to this ancient disease in most medical settings. I've learned a great deal from the many individuals from across the world with whom I've worked. First, that the decision to launch oneself into the unknown is never made lightly. It may not be a choice made with the level of certainty and planning that many of us would deem essential, and it is often made under the threat of violence. Second, that the goal of survival can be completely undone by illness, and those affected with tuberculosis often weigh seeking care for a treatable and curable disease with the danger of losing their livelihood, their home, and their tenuous connection to a social network cobbled together among souls also struggling to survive and fearful of anything or anyone that can knock them off their path. Third, that the pain of stigma and mistreatment at the hands of a fellow human being can damage a fragile sense of self beyond recovery, to be considered the other and found to be undeserving by someone whose circumstances could so easily be changed by weather, war, or world forces beyond their control can shake the person's very sense of humanity. And most importantly, migration need never be an impediment to health. Among the millions who migrate away from their country of birth is represented every group of persons my friends on this panel and on the previous panels have discussed. I have seen the success that can be achieved in assisting a person receiving treatment for TB as they move between communities, between states, and between countries remain in care. Thousands have received the medication and support required to free themselves of tuberculosis when there was political will and the necessary funding for effective national programs and community health projects. Often that political will was the result of advocacy from civil society who have experienced the impact of TB in their communities firsthand. Unfortunately, in the Americas, as internal strife and economic upheaval become commonplace, the very national programs that I witnessed trying to rise to the challenge are losing ground. Many of these countries lack access to first-line medications, not even thinking of second-line drugs, and all but a handful have registered for the use of Dilamidin and Bedaquiline. Much of my work was with individuals who were being involuntarily returned to their country of birth. While the sense of hopelessness that washed over so many of them as they saw their dreams of a better life dashed threatened to derail their progress towards cure, the clear knowledge that their future success required that they be healthy motivated them to adhere to a time-consuming and often debilitating treatment regimen. I fear, however, that as unauthorized immigration becomes criminalized, the effect will be to reproduce the inhumane and unacceptable circumstances seen in the world's prisons, where exposure to TB is used as a punishment and is a daily threat that invokes little sympathy. Those gathered today and those who will be present in these chambers in September have within their reach the capacity to change the face of human health and truly the very course of humanity. Eradicating tuberculosis can free a world potential so great as to reduce poverty, decrease child mortality, increase educational levels, productivity, and global wealth. The path forward will not be easy, but you have as your allies those who've been affected by tuberculosis and survived. Civil society and affected communities stand ready to meet the challenge and work with governments and other stakeholders to put an end to TB. But do not exclude them, because they are watching and prepared to act invited or not. Thank you.
Thank you, Deliana, and thank you to my strong panelists who have not only delivered powerful messages, but stuck below the time required. I now am faced with the challenge of dealing with 25 people who want to ask questions and make interventions, and I will trust that you will accord me the trust that the panelists gave me by using 1 minute to intervene so that as many people can speak. So I will start up first with TB Europe Coalition, followed by Reach India, then Results UK, Sea Change Initiative, America's TB Coalition, and then IHOA International Occupational Hygiene Association, and then we'll take it up from there.
Hi, my name is Jonathan Stillo from the TB Europe Coalition. And what we've heard today is really that we're living in two different worlds, places where tuberculosis services reach all of the people with modern diagnostics and the best available treatment, and where robust latent TB treatment is available, and other places where even the conservative guidelines of the WHO are not met. So ultimately, where one lives determines the quality of diagnosis and care that they have access to. And I want to remind folks that this has nothing to do with individual poverty and has nothing to do with whether people adhere to treatment or not. We have to enable people to do that. And what we need to start doing is looking at the minimum things which are required under the right to health. And there are some specific things that we can look at. For example, all of the drugs used for TB treatment are on the WHO essential medicines list, and providing those medicines is a core obligation. And that means that they're not subject to the principle of progressive realization. This is a minimum requirement. And the International Covenant for Economic, Social, and Cultural Rights was signed and ratified in the vast majority of countries. So this is legally binding, and we need to start there. Secondly, the right to science guarantees that all people should have access to the benefits of science. And what that means is that geography should not determine whether someone has access to smear microscopy or total genomic sequencing. We need to frame these demands in terms of human rights, and we need to end our toleration of different standards of care, which almost always mean worse care for the poor. Finally, I want to address people who say that we need to protect the new drugs. And I think this is sometimes used as an excuse for a lack of access. Those who make this argument tend to be based in wealthy countries, where those drugs are available if they or their families were affected by drug-resistant TB. Now, if all lives are equal, and they are, regardless of where you live, then everyone has a human right to treatment. So if we're serious about protecting the new drugs, then we must enable developing countries to make use of them. This is what human rights demand. Thank you.
Reach India, please, under 1 minute. That was slightly more, please. Let's try.
Good afternoon. I'm Anupama Srinivasan from Reach in India. One of the fantastic things for me today is that every single panel has talked about the role of communities, although there is a separate panel dedicated to this. I think all of us in the room today can agree that the TB response, both globally and nationally, is more inclusive of affected communities. Today's discussions is proof of that. The fact that we've had so many wonderful storytellers is proof of that. I'm not sure whether a meeting like this 10 years ago would have had as many TB survivors and champions at the table. So we have the momentum. So I think now is the time when we really need to push countries to institutionalize engagement of communities, to find ways to integrate it. It's the time to stop thinking of community engagement as a standalone, separate activity within our programs that we do, but really think of it as cross-cutting. TB survivors, affected communities are an incredible resource, whether it's for community monitoring, like someone said earlier, as peer support across the care cascade. And I think it's time we urge member states to commit to long-term involvement of affected communities and financing this involvement in the September Declaration. Thank you very much.
Next.
The UN high-level meeting is a unique opportunity to get the world on track to achieve the SDG target. This will only happen, however, if strong commitments made in the political declaration are translated into concrete action. The accountability mechanisms referenced in the political declaration are how we guarantee this happens. TB requires a multi-sectoral response overseen by a range of government departments. To be fully effective, these responses must be coordinated, and the only political authority that can do this is the head of state or government. And this should be reflected in the political declaration. In practice, this means the Secretary General producing an annual report for presentation to the UN General Assembly, TB being included on the agenda of existing regional and intergovernmental fora, and national TB strategic plans being revised to include delivery of the commitments in the political declaration, all with oversight and engagement of the head of state or government. It is critical that civil society and affected communities are actively engaged in all of this accountability, as they are often closest to the realities in most countries and have a unique and powerful accountability role. Thank you.
Thank you. Sea Change Initiative.
Thank you, Mr. Moderator. We were recently in the Canadian Arctic, and an Inuit woman community leader in Clyde River told us, basic human needs in our community are not being met. Until they are, we'll never be able to fight TB in the way we want. The Inuit in Canada, as Connie Sidule has told us, have been suffering and dying from a neglected epidemic of TB since the 1800s. Today, it's a crisis again. 17 of 25 Inuit communities in the Arctic are struggling with high burdens of active and latent TB. The rate of TB among Inuit is 300 times that of the non-Indigenous Canadian-born population. It shows us that today, TB remains fundamentally a human rights issue. All people should have the same access to quality, effective, culturally relevant and appropriate healthcare and medicines. They should not be facing lethal inequities. Canada is a rich country. It has the resources to resolve the crisis. And beyond diagnosing and treating TB, if they're serious about eliminating TB, the government needs to seriously invest in addressing the underlying socio-economic conditions in Nunavut. Unsafe and overcrowded housing is a critical starting place. TB must be eliminated in Canada and globally. Our current government has committed on paper to do just that for our northern communities. But as we also heard earlier today, words are not enough. We need action. So we're calling on the Prime Minister Justin Trudeau to come to the high-level meeting on TB in September and commit the necessary resources to end TB in Canada and fight TB globally. Thank you.
International Occupation Hygiene Association, your 1 minute starts now.
Well, thank you, Chair, and thank you, panelists. I'm not going to talk to you about medication or vaccines, but let's talk about worker rights then, as a part of people's rights. We already heard this morning about miners and health workers, two groups who have been identified as vulnerable groups in relation to TB. We estimate that 12% of the attributable risk in high-burden countries belong to these two groups. My message to you is that if you see these percentages, we have to decide today that we have to start doing things differently. As the president of the International Occupational Hygiene Association, I'm speaking to you on behalf of 20,000 occupational hygienists worldwide. And we are reaching out to you, offering our knowledge, expertise, and our willingness to assist you on this global task to end this global epidemic. As occupational hygienists, we are the expert in the workplace and eliminating work-related diseases and illnesses. We do it inexpensively and in a practical way. And we have successfully created TB-free workplaces in developed countries already. I'm urging you, the member states, to include workplace preventions within the statements. only then we can achieve together this goal. Because if workers are able to work in an adequately ventilated area, use the best techniques to reduce silica exposure, and work with the right respiratory protection, only then we can acquire TB in the first place, we can eliminate that. My message for you today is TB is also a work-related disease. Today we must acknowledge that. If you truly want to end TB, then our organization can help you, and we together can eliminate the work-related compound of TB. Thank you very much.
America's TB Coalition.
Es un indicador social y económico de un...
An economic and social indicator of the abuse of a human right, the right to life. We have to work together to do away with the political stigma which prevents access to health care to communities affected by TB, and the social laboratories of TB must also be taken into account, including governments, transnational corporations, and multilateral organizations. Thank you.
Indeed, muchas gracias. It was right under a minute. Well done. Yanaso?
Thank you very much for this opportunity. I just wanted to say that in the past, we used to hear, know your epidemic, know your response. With TB, we need to know who are the most vulnerable population, who are the key population, and that can be done through community research. And this can be done through partnerships with the national TB programs and the people who are the key population. So let us go out there and let us go look for the people who are most vulnerable and those that we are saying missing within the TB response. Thank you so much.
Apcaso, the standard has been set. Your minute starts now.
Moderator. According to the Global TB Report in 2017, Asia-Pacific region, around 20 countries reported data on the contribution of communities on TB notification or treatment support. In these countries, community-based activities attributed to a 16% increase in total TB reach. This shows how important the role of communities are. However, in the zero draft of the political declaration, we do not see any funding target on how much funding should be allocated to community-led responses from the total national budget to reach an effective level of community engagement. We need this target to make sure that countries translate their commitments on meaningful community engagement into a reality. Thank you, Chair.
Equity Innovations.
Thank you, Chair. My name is Refilwe Machi, and really it's a privilege to be here. I was doing a quick calculation. We have 16 weeks and 2 days left before 26th of September, or that's 113 days. And I just reflected and remember at one point I had to be trained by a specialist to get accreditation to prescribe ARVs in my country. But this practice changed very quickly as civil society, international and national organizations demanded a change to have and improve access to ARVs. These were the same drugs that were labeled toxic and complex. Today in TB, we're still talking about the good drugs labeled the same way, and we are delaying to expand access to them as people continue to die. Countries are now rolling out viral load testing, which again, this is a decision that has been taken for the past year or so, and yet the same countries have not moved an inch in rolling out SPECT or X-ray testing. We really need to ask ourselves what is happening. I was very encouraged to hear about Dr. Evan Harris, a British parliamentarian who is also volunteering to participate in HIV vaccines. When you Google HIV vaccines, there's a long list of trials happening, and you Google TB vaccine, the first word that comes up is BCG, which we have heard about for a long time. It's amazing that the Ebola vaccine was available so quickly and people were vaccinated. What would stop us moving next week, starting to provide preventive therapy for patients? Today, I can go to a dispensary and buy myself a self-testing HIV kit, which is already been rolled out in many countries. And for tuberculosis, we are just seated here. Drones now deliver drugs to the most rural areas for ARVs and for malaria. Nothing is happening on tuberculosis. Is it us who are failing ourselves, or is there something we're missing? Our targets are based on missing 40% of the cases. Is this realistic?
I'll have to ask you to wrap up. I apologize
that there's
for
a
that.
will,
Please
there's a
wrap
way,
up.
and we need to move forward. Thank you.
World Council of Churches, your minute starts now. Otherwise, others will not get a chance to speak. Thank you.
Thank you. I'd like to highlight the important contribution that religious leaders, faith-based organizations, and faith communities can play in supporting member states in reaching all children and adults exposed to and with TB. If the targets to be agreed in the political declaration are to be achieved to ensure inclusive, people-centered, gender-sensitive, and human rights TB responses, and for the successful mobilization of communities to take up prevention, testing, treatment, care, and support, partnership with faith-based organizations will be essential. Faith-based health facilities play a key role in health provision, especially in fragile health systems. They are providing between 30 to 70% of health care services, including psychosocial support and care in many countries. FBOs can count on strong community outreach structures, even in informal settlements. And empowered with appropriate knowledge and information, religious leaders can reach large numbers of people in places of worship, religious school, and institution. We need and we must involve religious leaders in efforts to increase public awareness and reduce stigma and discrimination on TB. Finally, to help ensure a meaningful outcome of the high-level meeting, faith communities are calling each government to be represented at the highest level in September and to commit to specific targets. Thank you.
The Union. It's the International Union Against TB and lung
Children have
diseases.
traditionally been neglected in the fight against tuberculosis due to the thinking that their inability to forcefully cough and spread Mycobacterium tuberculosis and thus had no impact on the spread of TB. However, the Union would like to emphasize the identification and treatment of children as a basic human right. Their rights to health already have been legally enshrined in at least 7 global and national treaties and human rights frameworks. This means the need to reach all people, including the 3.5 million children with tuberculosis by 2022. And it also includes prevention so that these children do not develop tuberculosis as adults. Thank you.
Thank you very much for keeping it within time. We will then move to the Alliance for Public Health.
To acknowledge the multi-sectoral responsibility far beyond the healthcare sector. Quality people-centered care should include psychological and social support for people with tuberculosis, which is particularly effective through support of the peers and communities. These measures make a difference for treatment adherence and for the quality of life of a person with TB. We have an evidence from Ukraine through Global Fund-supported interventions that even for MDR-TB patients, treatment success doubles due to psychosocial support. Political declaration and post-HLM accountability framework should include clear provision for for sustainable funding to ensure needs-based, right-based psychosocial support services, which should be integrated into the TB care packages.
We are back on track. So could we please have Auram Institute?
I wish to bring to our attention the painful neglect of the role of traditional leaders in TB who lead indigenous communities. For us in Auram Institute, we are well aware of the influence and the benefit that traditional leaders bring to our community-based activities. Political commitment starts from bottom up, from the communities we work in, and before it reaches elected officers. Traditional leaders, therefore, of communities gain their power and their influence from the people over whom they exercise their authority. And they are able to rally and galvanize them to respond to any enemy. At this point in time, TB is our enemy. Unfortunately, we have not taken advantage of the role of traditional leaders to fight this enemy. Political and elected leaders are members of ethnic populations and communities, and they owe their allegiance to traditional leaders. By getting these traditional leaders on our side, we have the benefit to use them to influence the politicians who unfortunately have become resistant to our direct approaches in whatever way we want to do. Traditional leaders would use people-centered approach to mobilize their communities, upholding their rights to advance our cause. As civil society organizations, wherever communities we find ourselves working in, we have easier access to traditional leaders and traditional leaders of these communities, and yet we have not channeled our efforts to get them on our side. Traditional leaders have influence that is far-reaching. They make things happen, and therefore we cannot leave them out. Thank you.
Colegio from Mexico.
Bueno, pensé que no nos iban a dar la palabra.
I have been asking for the floor for quite a while. I thought we were going to be given the floor. I come from the academic world. I think we need a third actor here, which is the governmental actor. They've been deaf, and they don't contribute at all except with a few years, supposedly, to reduce the incidence of TB. We have an infrastructure whereby we can't improve the situation. The question is, will cats end eating the mice? Will we have another violation where we're trying to do away with illnesses and we have so many stumble tones? Countries like Mexico, which is considered middle income, which means that we no longer get international contributions, and the poor regions which exist within every country, in Ecuador and Mexico, in Mexico, Chiapas, Guerrero, with tremendous systemic poverty, can never manage. The government is full of speeches and is not interested in the health of the population, and certainly not TB. We have 6% PBP for healthcare, but less than 0.05% of the BPI is devoted to TB. So the interests of the population are sacrificed. There are no funds for medication, research, or prevention programs. No research, few resources. TB is competing with other new illnesses, and its association with poverty is not discussed. But poverty is a very difficult issue when it comes to helping with TB. One proposal: the UN should coercive action, I'm not sure what to call it, which will truly compel governments to give access to the civilian population to funds and to improvement of programs.
Gracias. Save the Children, US.
Thank you, Mr. Moderator, for letting us have the floor. I would like to say that we agree with everything that everyone has been mentioning all through the day today. But and I also agree to the point that we do need new tools and innovative vaccines, new vaccines and innovative approaches. But while we're waiting for that, let's take a step back and think about what caused the success of programs like immunization programs, maternal health programs, HIV/AIDS programs. What really was the learning from there? We can easily take those learnings and translate that learning into action for TB programs. And one of the other questions that I would like to leave for us to think about and mull over is the fact that oftentimes, whether we're donors, whether we're implementers, whether we're government agencies, we're always talking about or looking for the low-hanging fruit, because at the end of the day, that looks sexy. Now, TB programs or TB screening, diagnosis, treatment, adherence, compliance, and all of the above really is a very costly matter. So is that sexy? Probably not. So I think that's something we need to think about. Thank you.
Thank you. University of Malawi College of Medicine, your 1 minute starts now.
Thank you. My interaction with TB comes from the fact that I'm a medical doctor, I'm a researcher, and I have gone through TB episode myself, suffered it, and gone through the treatment. That is very long. And like others, I appreciate the need to have new drugs, new vaccines, new interventions. But the key to getting these into populations, for these interventions to have the rapid benefit that we want to offset the current worrying trajectory that we have, we will need applied research. This is what is going to give us the success that we need. The equitable distribution of the benefits of all these interventions that we are talking about cannot be realized without having emphasis on applied research. So if this document that is going to come out of the September meeting leaves out applied research, then it is not complete. Thank you.
We have 10 minutes left for this, and I still have 10 more people on the list. So if you keep to your minute, we can take up everyone. I will take up the red TB luck. Your 1 minute starts now.
Muchas gracias.
Thank you very much. I'd like to take this opportunity to say that in the panels, we've had experiences of individuals who've survived this disease, which means we have to think a lot about the lack of response of the healthcare systems that have failed us. Some people have recovered, but late. But we cannot allow so many people to die or to see this violation of human rights, which has been clearly shown in so many cases where people's rights were not taken into account. The declaration has to focus on interculturality, human rights, and the most important one being being respect of human rights. And the declaration must emphasize investment. There has to be more investment for a response to put an end to TB. And it must also stress that civil society shouldn't just listen to the accountability of people. It should fully participate in the implementation, evaluation, and accountability. Thank you.
Muchas gracias. Tropical Disease Foundation.
Hello? Okay. Hello, everybody. I'm Louise Pedateng, and I'm also part of ACT AP, Asia Pacific. And I am a former tuberculosis meningitis patient, and I'm now totally blind. And the reason I think why I had to experience this is because I need to discover a whole new population that is being neglected. It's the disability sector. And there is a United Nations Convention for the Rights of Persons with Disability we're supposed to be implementing in the country, but nobody seems to know. And for me, I have been discovering a lot of cases, children with learning disability, autism with primary complex, no treatment is being given to them because they're hard to treat. Deaf and mobility impaired that are not being given the needed reasonable accommodation because nobody knows how to talk to them. So I believe we are supposed to be catering to the 1 billion persons with disability globally who's being neglected with this service. So I hope you don't have to see literally what I see before you understand what I'm talking about. Thank you.
HAD Nepal Forum.
Several TB communities, including key populations and people affected with tuberculosis, are beyond the current partnership net in TB control when it comes to the functional partnership and respectful partnership in the context. Several barriers at national and international level impede meaningful engagement in TB. They need to be identified and acted upon. Our current approach in TB control places greater focus on biomedical care, which is important and needed indeed, but it should not undermine the importance of patient-centered care and right-based response in TB. The resolution should adequately address this notion and end unbalanced partnership in tuberculosis control. Considering the diversified community and their roles and needs, vital needs, it is important that significant investment are to be made in applied research in each country, leading to community-led solutions for better partnership and appropriate care and context and sustainable partnership in the long run. Thank you.
Chamber of Mines, South Africa.
Minerals Council South Africa, formerly the Chamber of Mines of South Africa, is honored to make this intervention. The South African mining industry has a long history of dealing with TB and silicosis, with gold having been discovered in 1886 and TB classified as a compensatable occupational disease in 1916. The experience of the industry is that success in reducing TB and HIV is possible and sustainable when this is based on addressing the determinants of health, preventing silica dust exposure, and improving access to comprehensive health services, including TB services. Improvements in salaries, housing, and living conditions for employees in the mining industry has, over the years, contributed to reductions in TB incidents. Our humble contribution at this meeting is that TB must be managed in an intersectoral manner. The primary causes of TB, as well as its determinants, should always be addressed. Governments need to provide greater stewardship in occupational health. In conclusion, the Mineral Council South Africa endorses the ICOR statement on silica TB and encourages other partners to do likewise. Healthy workers make healthy nations. Thank you.
London School of Hygiene and Tropic Medicine.
Hello. I'd like to take my time to emphasize the economic consequences of TB. And from an economic perspective, TB is not just a health priority, it is also a developmental priority. The World Bank, since 1993, recommended TB as part of the essential package of health services. More recently in Malawi, it was in the top 3 of the top 10 health interventions from an economic perspective were related to TB. In Bangladesh, when 70 economists looked at different TB interventions, TB was the top development intervention, beating other infrastructure and other sectorial investments. And that is not taking into account the numbers of cases of poverty that can be averted through addressing TB. We need investment cases and strengthened investment cases for TB, but specifically we need to look at investments in health systems. If we look at South Africa, to expand case detection, intensified case finding would take up to 20 to 30% of the total nursing workforce in South Africa. Unless our investment cases address these kind of resource needs, we will not be successful, and we need applied research to help support develop those investment cases and provide the evidence we need in that health system strengthening investment. Thank you.
I only have 5 minutes for more interventions, and if you could stick to 1 minute, I can take 5 people, but if you take more, the rest won't be called, we'll call you out for it. Project Hope, 1 minute to allow 4 others to speak in 1 minute.
Thank you for giving me the opportunity to speak. The involvement of community and civil society is not to TB is not questioned anymore because of the very good examples from many countries showing the result from the contribution of the community to TB detection and treatment. We have very good examples of targeting most vulnerable population in Central Asia. Good example of working with labor migrants in Kazakhstan to improve access to TB diagnostic and treatment, and targeting vulnerable populations such as injection drug users, people living with HIV, and prisoners and migrants in Tajikistan and Uzbekistan and other countries. So my key ask to the head of states would be to allocate funds for community, civil society engagement to target the vulnerable population, work with them. And the second ask is being from middle low-income countries, and knowing that most of the time our government, even if they are willing to, they cannot allocate more funds to TB. We can provide some suggestion. For example, now we have many examples of involving the private sector and businessmen to build more parks and beautiful buildings. So the government can really...
You need to wind up, others will not speak.
The government can really push the private sector to be to have social responsibility to provide funds for community engagement. Thank you.
1 minute, literally, TB people, Ukraine, literally.
Dear colleagues, we are talking about children and prisoners and others. Whether we treat people whom there is no cure, palliative people. If, to speak an example, my country, it is now 100 people. What is our voice in this issue? Everyone has the right to help and support, and all countries should guarantee needed services, care for people with palliative conditions. Thank you.
Awesome, and I'll use my discretion to have the last intervention of the day from O'Neill Institute.
Thank you. The success of the TB response depends on strong civil society, and I hope that the civil society leaders in this hall today will make efforts to tell member states that in order to be sincere, their talk of partnership with communities must be accompanied by efforts to address the funding crisis that leaves the best of us on our knees gasping for funding. The high-level meeting on TB must result and commitments to channel funding to civil society organizations on the ground in countries affected by tuberculosis who fight for their lives by seeking to hold public and private power to account. Strong civil society is necessary. Without it, we will fail. Strong civil society requires funding. We must demand it, and we must fight for it. In that vein, we civil society members in this hall today have been put on notice by the representative from the United States when she says that issues of intellectual property are a distraction. We have been put on notice that there is an effort to undermine the right of access to life-saving medication. And we should recognize that that threat comes accompanied by niceties about funding for research and development. It is a wolf in sheep's clothing. We must recognize it, we must name it, and we must fight it. Thank you.
Thank you. I know there are people who are on the list that didn't get to speak, but we've tried our best to balance in the circumstances. I will turn it over to Deliana to wrap it up from her perspective. I see your hand, but time is really up. We have to stop now. Deliana, please, your final thoughts, and would you let us know one right you'd like to see that is included in the declaration by the heads of states?
Well, and the right that I want to see is that it be human-centered, and that the UN support its own work already, which is that the resolution that was adopted for the protection of migrants. Their work already includes a focus on migrants, and that needs to be sustained throughout.
Thank you. Maxime?
Merci. Moi, j'ai vu.
Thank you. I'm going to focus on human rights. To say that improving legal environment is essential to ensure the protection of those who are ill with tuberculosis and to guarantee equal care for all. Without this, we will never achieve reaching those who do not have care, and we will always see those who are abandoned and not given care. Thank you.
Connie?
To be mindful that for Canadian Arctic people, we are losing ground to TB. At its peak, 1 in 7 Inuit were moved to TB sanatoriums. Rates were 2,500 per 100,000 in 1960. These were reduced to 200 per 100,000 in 1980. Unfortunately, incidence is now currently back on the rise, exceeding those rates achieved in previous decades.
Thanks, Connie. Timur?
Well, speaking the human rights language, TB does not have a right to exist. And we have a right to a world free from tuberculosis. For that to happen, we have to come together in September with heads of states, because for that right to happen, we need commitments from everyone. It's not just the governments. It's civil society, it's private sector, it's the affected communities. But we have the highest level of commitment possible. TB does not have the right to exist. Thank you.
Blessy.
Thank you very much. Before I say my ask, I just want to correct one of the colleagues who made a comment that TB is very expensive. I think that's really a mistake, because the Copenhagen consensus actually shows that it's extremely efficient to treat TB. For every dollar that you spend, you get $92 in return. So let's not, kind of be naive and say that's why we're not able to end TB. We're not able to end TB because people are not investing enough. So for me, the ask is that people affected by TB have to be at the center of the response. We've heard about it from morning, and the danger here is to make it happen just as a tick in the box. So let's not do that.
let's actually agree to invest in building the capacity of the affected community, of the key populations to have a voice in shaping the response, and commitments from missions, governments, civil society, donors, technical organizations to invest so that we do not have drugs that make people commit suicide, that we do not have painful injections that people have to take, hundreds of them. If the affected community were part of those decisions, would we have things that are so against human rights, that go so against being people-centered care? So let's put people at the center and make this happen and end TB together. Thank you.
This has been a very enriching panel, and before I totally wrap it up, I just want to appreciate the panelists, those who had an opportunity to speak, and all those who were able to make submissions. I think from the conversation, I think it's pretty much clear that the rights-based approach is not just an aspiration, a concept which we pay lip service. It has specific content, including recognizing and fulfilling rights of people through laws and policies that our governments are obligated to put into place. We must ensure that people get their right to life, because we are told we have 4,500 people dying daily. We must ensure that people get the right to the highest attainable standard of health. We are talking about people who have to take medicines that make them become deaf. This should not happen. We are talking about stigma and discrimination, and we're not mentioning the right to privacy and confidentiality, which is very critical and fundamental to addressing the issues of stigma and discrimination. We are not talking about informed consent. We're not talking about access to information and giving people quality information so that they can make decisions that would ensure that they adhere to their treatment. And we need to talk about the importance of scientific research and investing in that to be able to get newer and better drugs, because I know no one in this room would want to be subjected to medicine that puts you at a risk of getting deaf. I don't think anyone would want that to happen to them. And so the rights-based approach is calling upon us, whether government, whether civil society, whether a healthcare worker, to embrace certain principles. The principle of participation, the principle of accountability, the principle of non-discrimination. You want to empower communities so that they can come up with sustainable responses towards ending issues around TB. So it is important and it is imperative that the draft declaration that is out speaks specifically to this issue, and most importantly, the issue of access to medicine, which is currently not recognized in the draft, is something that needs to be included in the draft and a solution provided for it. Thank you for listening. Thank you for your contributions, and see you in September with your heads of state when we come back with more demands as civil society to ensure we have a strong and powerful political declaration that will drive us towards ending TB by 2030 in line with our Sustainable Development Goals. Thank you. Just as a matter of protocol, I'm advised the closing session will start in a few minutes, so you're requested to kindly remain seated, save for the panelists who have to transit back to their chairs. Thank you.